what is POTS?
Your autonomic nervous systems are not responding properly. When she would stand up, her heart rate would go from 85, 90 to 220. So toxins and other chemicals that could be potentially dangerous for the brain, it doesn't want them in there. I've seen other people drop into 100 teens and then they start seizing. 1% of 18-year-olds are still wetting the bed.
Dr. Scott McMahon, thanks for being on the pod today. And we have talked a lot. I've asked you for counsel on POTS cases and PANS cases. And we know that you're getting ready to publish on PANS. Today we're going to focus on POTS. Can you tell our listeners what is POTS?
POTS are things that you find in the kitchen that you use
that you cook up chronic illness with.
That you cook up, yeah, a little eye of newt and POTS is the pediatric Postural Orthostatic Tachycardia syndrome, and what we're really talking about is when people change body positions. So they go from laying down to sitting, or from sitting to standing, or even from laying down to standing. There's a dramatic drop in their blood pressure and their heart rate goes up. The first patient that I ever saw with POTS, when she would stand up, her heart rate would go from 85, 90 to 220.
Wow.
Now, I've seen another syndrome called orthostatic hypotension, which is really common in teenagers. In part, I think it's because they don't drink, or when they do drink, they drink, carbonated beverages instead of water. And particularly if they get like a sore throat and they're drinking even less water, they would frequently get this orthostatic hypotension. So their heart rates would not go up to 220, they go up to like 120. Or maybe 10 points higher than when they were in their previous position, like sitting to standing. There'd be a 10-point difference in heart rate or a 10-point difference in diastolic blood pressure, but not anything like what we see in POTS. So the way I understand POTS is that you have a combination of things happening, particularly in CIRS patients that have chronic inflammatory response syndrome. One of them is that almost all of them have some degree of dehydration. At least 86% of our patients have an abnormality in their antidiuretic hormone production and their serum osmolality. Now that's a lot of doctor speak, so if you don't mind, I'll break that down. Serum osmolality is a measure of how thick your blood is, how concentrated it is. It's looking at the amount or the volume of the actual blood volume and the amount of what we call solute, things like sodium and potassium and other things that are dissolved into the blood. And we call that osmolality. And as the osmolality rises, it means you're getting more and more dehydrated. And there's a certain normal range. Like usually the range is 275 to 295. If you're over 295, to some degree, you're dehydrated. And there's a chemical in your body that's called antidiuretic hormone, or ADH. And when your hypothalamus, it's a little piece of material up here in your brain, it's like the CPU of your brain. It takes inputs from all over your body and all over your brain, and it makes decisions for your whole body. And it says, okay, I need more blood pressure here. I need faster heart rate here. I need deeper breathing here. I need hairs to stand on end. I need pupils to get big. I need all these different things to go on based on the situation that your body is in at the time. It's really fantastic. That's the hypothalamus. And the hypothalamus controls the endocrine system, or the majority of the endocrine system, by telling the pituitary gland, which is right underneath it, what to do. So hypothalamus measures the serum osmolality 24/7. It directly measures it from the blood. And when it's getting too high, it sends a message to the pituitary that says, release that antidiuretic hormone.
Which we tell patients is anti-peeing hormone.
Anti-peeing hormone, exactly. ADH. Maybe we should change it to APH.
APH.
Okay.
Yes.
Yeah, I think never. I was going to make a Blackpink joke there, but I don't think so. Okay. Do you know who Blackpink is?
No.
Oh, they're a K-pop group, and they sing a song now called APT. instead of APH. There I go trying to do pop culture.
Do you wanna pee with me?
Yeah, something like that. That's a nice hat, by the way.
Thank you.
Anyway, so this antidiuretic hormone is made in the pituitary hypothalamus. It's made and stored in the pituitary, and it's released when your osmolality is getting too high. And so it travels in the bloodstream down to your kidneys, and it tells the kidneys, stop making urine or slow down on the production of urine because we're getting too dehydrated and we don't want to pee all that free water out of our body. So slow down on that. And at the same time, you get thirsty. So you drink more fluids and you pee less, and now you have more free water. And so what happens then is your blood gets a little more diluted. So you go from being too concentrated to a better range. And alternatively, if you're too waterlogged, if you have too much free water, then what happens is you don't secrete antidiuretic hormone. And so you don't have that signal going to the kidney, so the kidney just makes urine, and you pee like a racehorse. Okay? So as the osmolality rises, the antidiuretic hormone is supposed to rise. And if the osmolality is dropping, the antidiuretic hormone is supposed to follow it. Okay? What we find in 5 out of 6 CIRS patients, 86%, is that the osmolality is either too high or right near the upper limit of normal. And the antidiuretic hormone, instead of being too high, is too low. Or sometimes it's way low, like you can't even measure it. It's non-existent. And so what we find in our CIRS patients is they often pee like a racehorse, and then as a result of that, they just drink and drink and drink because they're thirsty, but they don't have any antidiuretic hormone to keep it in them, so then they just pee it all out. Now, that's a couple of the symptoms that we see in CIRS, and that's a couple of the blood tests that we do, and that's why we do them, because we see this all the time. That's one part of POTS, is that you start out volume depleted because you're urinating all the time, sometimes 10 times a day, sometimes over 20 times a day, sometimes 5 or 6 times at night. How can you sleep when you're getting up 5 or 6 times at night to go to the bathroom?
Must be my prostate, not the moldy building.
I'm sure that is. It's particularly in your 20s and 30s.
That's right. It's particularly my 12-year-old pediatric.
It's like I got a D3 kind of prostate or something. So it's just hypertrophy now. So that's one issue. Okay. Yeah. Now there's a second issue here. And again, I'm going to go through a big explanation for your viewers so that they can understand this. But it's a little complicated. Okay. Now, throughout your body, you have blood vessels. We know that. Okay. When I was in medical school, I always thought of a blood vessel as kind of like a garden hose. Like the water, goes in one end, it comes out the other end. And that turns out that's not true. Okay.
It's more like a soaker hose.
It's more like a soaker hose. It's like you took that garden hose and a pin and just poked a bunch of holes in it. Totally. See if I can keep hitting my microphone here.
Yeah, but it really is almost like this microphone cover here.
Yeah. And so they're very porous, and fluid and small proteins and whatnot can get out through those holes and go into the tissues, and the tissues love that, I guess. It's like an extra snack. And if there's too much, the lymph system will clean it up, and if there's way too much, you'll get some edema. Okay. That's the way most blood vessels in your body are. Okay? But the arteries that go to your brain, that feed the brain, when you're first born are like that. But by the time you're 5 days old, brain cells have reached down into those cells and they create what we call the blood-brain barrier. They create another name we call is tight junctions. So instead of having these loosey-goosey junctions, and junction is just where cells touch each other. Loose junctions, fluid can flow through them, those proteins can flow through them, it's no big deal. But if you have tight junctions, then nothing can flow through them, it's very difficult to get things to flow through.
Selective.
It's selective, and it takes a lot of energy. So the brain actually expends a great deal of energy creating that blood-brain barrier and keeping it intact because it doesn't want every chemical that's in the blood.
I don't want mercury in my brain.
Exactly. So toxins and other chemicals that could be potentially dangerous for the brain, it doesn't want them in there. Same with certain cells. It doesn't want them to just come out and go into it and create havoc. Okay? So again, by 5 days of age, babies have created this blood-brain barrier. So it must be important. Well, moving forward, that blood-brain barrier in CIRS patients can be either breached, like holes made in it, or the permeability of it can be changed so that more things can go into the brain than used to be able to. And that happens because chemicals like C4A, MMP9, TGF-beta1, when they're elevated, they all can cause those kind of breaches in the blood-brain barrier. Other chemicals that we see usually affected in patients who have CIRS, like VIP, vascular endothelial growth factor, or VEGF, when these are low, then they don't maintain the blood-brain barrier the way they're supposed to. The others are cytokines. They actually degrade the blood-brain barrier. And we see all 5 of those chemicals at times are abnormal in CIRS patients. You only need one of them to be abnormal, but we see all 5 at times. So we know that it would be nice to do some like autopsy or brain studies to verify this, but we know that under those conditions that the blood-brain barrier becomes more porous, and that allows chemicals to go into the brain. But some scientists have shown that that also allows cytokines. Now we know cytokines are the big bad guys in chronic inflammatory response syndrome. They're what cause our symptoms. They're what make things bad. And we know that if there is a deficit in the blood-brain barrier, and you also have extra cytokines in your body for whatever reason, you could have the flu, you could be having an allergic reaction, you could be having an autoimmune reaction, concussion. So TH1, TH2, TH17, trauma, whatever causes that. If you have an excess of those cytokines and you have damage to the blood-brain barrier, guess what? Now these extra cytokines get into the brain and they cause inflammation, low-level inflammation, but inflammation in the brain. Okay. Now let's take that one step farther to bring it home. Okay. That's a lot of foundation, I know that. So the last thing that I mentioned is that the hypothalamus, this big regulatory organ of the brain, that it has 3 main functions. It actually has more than that, but 3 big ones. One of them is through various chemicals, it signals the pituitary, the master gland of the endocrine system, and tells it what to do. It's like it's the principal, and the pituitary, the hypothalamus is the principal, the pituitary is the teacher, and the principal tells the teacher what to do, and the teacher then tells the students what to do, through the hormones going through. So that's one function, is the endocrine system. A second function of the hypothalamus is that it controls certain set points in your body, or what some people call thermostats. I call them set points, that have to do with hunger and how you're going to metabolize food, have to do with sleep cycles and whether you wake up rested or not, have to do with temperature, what your actual body temperature is, but also how you perceive temperature. And we see abnormalities in all of these things in our patients.
I ask them on the cluster symptoms list.
Exactly. And we see abnormalities in their endocrine systems too, their hormonal systems. The third thing that the hypothalamus does is it controls the tone of the sympathetic and parasympathetic nervous systems.
There it is.
And there it is. That's the second part of POTS, is that there's an abnormality going on in your autonomic nervous system, so that when you stand up and change positions, instead of having that heart rate that goes from 90 to 120 or 115, you have the heart rate that goes to 160 or 180 or 220, because your autonomic nervous system, sympathetic and parasympathetic, are not responding properly. Why is that? Well, I got to believe it's because of the inflammation that has pierced the brain and is now causing that low level inflammation. And not only that, but there are parts of the hypothalamus that are not even covered by the blood-brain barrier. And so they have direct access to the blood supply and increased cytokines there also. So when you take that combination of a fluid derangement going on where you don't have enough fluid in your body, and you add to that an over-exaggeration of the sympathetic nervous system, to me, that's what POTS is.
Okay, let's ground our listeners, because that was a dissertation. And what's so cool about that is I was realizing we've been friends and besties and CIRS and helping each other get better as doctors for a decade. Yeah. But if you're really into ADH, POTS, Dr. Scott McMahon on CIRSX.com, you can go look at old conferences, and you have the best talk titles ever, right? One of your 2018 talks, and you can go under resources and you can go to the old conferences, and then we also have them curated. But in 2018, your talk was Pots and Pans.
Pots and Pans.
I thought it was the best talk title ever. And then you did to pee or not to pee.
That is the question.
And that is the question. And that's where you did your first ADH. And you leveled up. Like, you're the pediatrician who knows diabetes insipidus. And diabetes insipidus is just the diagnosis name of what you have for low ADH.
Yes.
And then you, last year at Frisco, did pee all you can pee.
Pee all that you can pee.
And gave a little shout out to the Army commercials I grew up with for all of our vets with CIRS and our active duty who are working in Moldy Barracks. I'm sorry, I'm ashamed. And pee all you can pee. Let's ground people in a bunch of things. First, you said orthostatic hypotension. And I think that's the majority of what I see in clinic is you stand up and you don't have a systolic increase in your blood pressure from adequate sympathetic tone. Your blood pressure goes down a little bit. Your heart rate goes up a little bit to compensate. You're talking POTS is it goes down and blood pressure goes through the roof. And technically to get an accurate ICD-10 code where you could write POTS as a diagnosis, you need a tilt table test, right? And that's how you really do it. You can do in your office, take someone's blood pressure lying down, have them stand up, recheck their pump, and get some basic screenings, almost like you can with an overnight oximeter for apnea. But a real sleep study is more like the tilt table test, right?
Right.
Then you really clicked for me years ago, well, how do we build blood pressure? And I always thought, okay, you build blood pressure with a hormone called aldosterone. Mm-hmm. And aldosterone's name is blood pressure hormone. Cortisol's name, or glucocorticoid, is blood sugar hormone. Right. Cortisol is the hormone that your hypothalamus pituitary adrenal axis is supposed to release to raise blood sugar. Right, I'm going to cut glycogen into glucose, and that's why when someone's cortisol is spiking all the time, they're going to go diabetic because their glucose is too high. But if they're hypoglycemic, we're going to see that CIRS morning AM cortisol or glucocorticoid at 7, and they're flatlining and they're waking up tired from hypoglycemia with a 72, right? That's our blood glucose. The hypothalamus pituitary adrenal axis also does aldosterone, our blood pressure hormone, which doesn't get enough play in medicine. And low blood pressure and low blood sugar are almost always together because both those hormones come from the cortex of the adrenal via the hypothalamus pituitary, right? And aldosterone holds on to sodium. Cortisol brings up glucose, aldosterone brings up sodium, water follows salt and increases blood volume, which should increase blood pressure. And the reason I share this, and I know you know all this, is so many of our listeners with POTS have then gone to the POTS expert and they get imitation aldosterone, which is a drug called Fludricort. Right. And I am not anti-Fludricort. Fludricort can actually increase sodium, which increases osmolality, and water follows, and then they get a little bit of benefit in pressure. What everyone's missing is the diabetes insipidus, which is the fancy name to say low ADH, which is secondary to CIRS, chronic inflammatory response syndrome, also known as mold illness, biotoxin illness, Lyme tick resulting in Lyme long hauling, co-infection, recluse spider venoms, actinobacteria, water damage bacteria, endotoxin. All of these biotoxins can turn on innate cytokine storms that then break down my blood-brain barrier, injure and hang over my hypothalamus pituitary function to do all this homeostasis.
So they're just missing the root cause.
And you're flying to Munich and down to the specialist in Texas and spending tens of thousands of dollars, hundreds of thousands of dollars for your daughter, and you needed that money to fix the building, right? So that's why we're trying to get the word out. There's one other thing that I explain when I explain POTS, because I started on the ambulance. I started volunteering hospice and on the ambulance. And when you go into shock, that would be a severe vasodilation and lack of sympathetic tone, right? And we would put on shock pants. And I never got to use the shock pants. But we practiced and trained on them.
They're pink, right? They're shocking.
They're hot pink pants that you put on at the club, and then you pump them up, and they literally create an artificial arterial, right? And our big honking aorta turns into a muscular arterial, which then turns into capillaries, right? And those arterials, as you were saying, is where that, when we release norepinephrine quickly, because we stood up and we don't want to go like this, our hypothalamus pituitary says, tighten that up a little bit, right? And our sympathetic chain says, tighten that up a little bit, right? And we hold blood pressure in our head, right? So all of that.
Because if you go even 4 beats without getting adequate blood flow, you pass out.
And that's part of you could argue that's part of the body's compensation, is let's go from vertical to horizontal so that my heart and my brain can be on the same. And then in emergency medicine, you lift those legs, right? To try and get the blood to the head. Right.
Exactly.
So should people go through life on a recumbent bike with their legs up and check email? No, we should be able to have a thermostat or a CPU, a motherboard, a command center control that regulates this, right? And I think people need to know that when we ask the clustered symptoms in people. And for those of you who don't know what clustered symptoms are, these are 37 symptoms that Dr. Shoemaker saw in at least 30% of his 10,000 biotoxin ill, right? So like 95 to 98%, regardless of the biotoxin, cyanotoxin, Lyme. And this is why I've argued with other doctors and said, you can't make a screening for Lyme. It's a screening for CIRS. Because the overlap of biotoxin illness symptoms, whether it's an algae bloom or a moldy building or a Lyme building or a recluse spider bite or a Lyme tick or a co-infection or a sewer gas leak, there's like 90% overlap. Right? Or more. So the clustered symptoms, like they all have fatigue. But then you start getting into some of those that are low ADH specific, right? And one of those is hypovolemic headaches, right? If I don't hold enough fluid in my brain, I get a dehydration headache. The other one that I'll never forget, Dr. Shoemaker explaining to me, when your blood volume goes down, your osmolality goes off, you will rise sodium to the outside of your fingertips, and you will shock things more. You will shock the dog more, the doorknob, and then you go, oh, well, we have lots of carpet, we're in dry Colorado. Yeah, all true. Also can increase shocks running across the carpet with your slippers on, but you have CIRS.
That's right.
And the static shocks were always Voldemort.
It's like the Emperor on Star Wars.
Well, that's more. It is. Join the dark side. I will not live in this moldy building. Join the dark side. I will not have static shocks forever.
Exactly.
And the other one that I noticed that's not on the cluster symptoms list is dried lips despite drinking water. Right. These people drink and drink and drink. The other one is
get diagnosed with Sjogren's syndrome.
And get diagnosed with dry eye, and that's real too. It can be you can have Sjogren's antibodies. You can have Sjogren's and CIRS, and you can have CIRS masquerading as Sjogren's. Right. So then you were. So we talked about a couple things I just want to bring up, and then want to hear you your take on this is the guy who started as a pediatrician. You taught me frequent urination is one of the number one SIRS symptoms.
Yeah.
And you taught me, I was like, well, what's frequent urination? And I remember you said you drink a couple liters of water a day and you should pee 4 to 6 times.
3 to 4 times.
3 to 4 times. And then I started counting frequent urination as 6 to 10 times. Mm-hmm. And then you taught me there's very frequent urination, which is 10 to 20 times. Yeah. And then there's extreme, which is greater than 20. Right. And I'll never forget my first greater than 20. And she had to bring her laptop into the women's stall to get her work done.
Wow. Because
she would pee and pee and pee and pee. So just pee and she'd kind of just wait there. And people who have low ADH, they can check some email, pee, and like 2 seconds later, they're peeing again.
That's really a laptop computer.
They need that CPU. Yeah. So the other one is we talked when we were talking about POTS, and we talked about, hey, if you have a kid with fatigue, tummy aches, headaches, and you can't explain them through other pathophysiology, you could have tummy aches, fatigue, and headaches from celiac. Right, you could be iron and D and B12 deficient and have chronic malabsorption. Bedwetting. If you don't have funny business, there's no molestation history, there's no urinary tract infection, and you have a kid who's out of daytime diapers and they're wetting the bed, or you did the SIRS work, they're in a clean building, they don't wet the bed anymore, but when you go to a moldy hotel, they wet the bed.
Exactly.
You are probably looking at a SIRS child. Would you agree?
Yeah. So in pediatrics, we know that 40% of 3-year-olds are still not potty trained, 30% of 4-year-olds, 20% of 5-year-olds, 10% of 6-year-olds. They're almost all boys. So if you get to 6 years of age and you're not toilet trained, good chance it's SIRS. It could be urinary tract infection. It could be other things. But if you rule those out, you got to look at SIRS. Mm-hmm.
Now, wouldn't it be interesting to look at those 10 and 20% that aren't catching on and see if they're SIRS?
Yeah.
So I did a thesis, a micro-thesis at Bastyr. And I went through like all the potential naturopathic treatments for bedwetting. And this is before I knew SIRS. And the current standard of care in the American Academy of Pediatrics at that time was a shock pad.
Oh, yeah. Uh-huh.
Do you remember those?
Oh, yeah. I prescribed those.
So can you tell our listeners what a shock pad is for little Timmy? Should I start saving for therapy now?
CIRS, you remember CIRS, not CIRS, but SEARS. They were a catalog store. They had a medical catalog.
Wow.
And that's where we would order them from.
That's where you get your shock pads.
So I give people the phone number and say, order this. And so the idea behind the shock pad was just like Pavlov's dog. And so as soon as that first drop of urine came out of little Tinny's wazoo, that first drop, it would create a shock and it would wake him up. And then, I need to go to the bathroom. Yes. And then you go to the bathroom and you do your thing. And supposedly it only took maybe 2 or 3 or 4 times of that happening to where you would start to feel the urine coming out and you would wake up and you wouldn't need the shock anymore.
I'm sure little Timmy sleeps really well. Doesn't have any restorative cycle issues.
I'm certain of it.
After growing up with his shock pad.
If I prescribed it, it was okay.
Is that like your demonic huggy blanket?
Something like that.
Shocky.
But the other thing that we prescribed, though, was synthetic antidiuretic hormone.
Yes.
We use Desmopressin or DDAVP in the little kids.
Yes.
So after the shock pad didn't work.
So that's where I would like to wrap up today, is explaining to people that POTS is a symptom. It is not a diagnosis. POTS secondary to chronic inflammatory response syndrome, secondary to my water damaged building or whatever. I can get with that as a diagnosis, right? It's a full explanation of why POTS, right? So on the Shoemaker protocol, which is built like a pyramid, step 6 is correct antidiuretic hormone. Can you give your experience about what happens if the first 5 steps are really lockstep and barrel? How many people need to get to 6? do I ever need Desmopressin or pharma ADH for life? How many people in your thousands of patients needed long-term ADH, so on and so forth?
Right. Yeah. First, I have a question for you, though.
Yeah.
So we know that there are 37 clustered symptoms.
Yes.
Right? How many cloistered symptoms are there?
What's a cloister?
It's a nunnery. The answer is none.
Hey, all right, not bad.
So yeah, okay. How many cloistered symptoms? None. Okay, that's the way it goes. And then you laugh. Yeah, cloistered.
Know.
That's where the nuns go to the nunnery. Get
did
thee
you
to a
know,
nunnery.
Did you know that diarrhea is genetic?
It just keeps running on and on.
It runs in your genes.
It runs in your genes. Is that like Lady Gaga's genes?
Well, I'll tell you what, I'm pretty sure we got CIRS there.
That was a different podcast.
Yes,
yeah,
that was.
Yeah. I was going to make a joke there, but I stopped.
Once you see it, you can't unsee it.
Yeah.
And as you kind of go into the ADH, I will say I recently had a teener who was still wetting the bed at sleepovers. Mm. And to be able to explain to him this is not a spiritual crisis, a personality disorder, or an emotional situation. This is corrupted biochemistry. It's called CIRS, and it crashes your antidiuretic hormone. And as we get you in a clean building, give you well call, pull these biotoxins to the toilet, and have your hypothalamus pituitary reset, you will not be having accidents anymore. As basically a grown man, right?
Yeah, and I mentioned before, that 10% of 6-year-olds, almost all of them are boys, are still wetting the bed. 1% of 18-year-olds are still wetting the bed.
That's got to be a
and
CIRS
then
patient.
You got to send them to the military or something like that. But it reminds me, when I was a teenager, maybe 12 or 13, there was a movie on. It was like, Monday night movie or something like that. And Michael Landon, I don't remember who he was playing, but he was playing a teenager who got really good at running because every time he wet the bed, his mom, in their 2-story house, she would take the sheets out and she would put them on the upstairs banister so that everybody could see. And so he got good at running so that because he would run from high school all the way home so he could get there and pull the sheets before his friends came by.
These kind of things without medical, biochemical, physiological explanation can really make a person lose their mind.
Absolutely.
And I'm so grateful that you're here and we're talking about, hey, is your 6-year-old, your 9-year-old, they don't wet the bed, but then you go to a hotel and they wet the bed, that's a CIRS kid.
Yeah.
And maybe you have to prime them with well-called colesevelam before traveling. And maybe you have to spend a little more time looking for a new construction hotel that is less likely to do that. So how do we when do we apply step 6 of the Shoemaker protocol, correct ADH? How many times you see you don't even have to do that if you get through the first 3 steps? And
if I can just throw out one more, and then I will finally answer that question, or I might have another joke.
Yeah.
Part of the workup for a child who's 6 years old and still wetting the bed is not checking ADH and osmolality. Nobody checks that. As a pediatrician, you're not trained to check that. I don't know that urologists check that on people unless they actually suspect diabetes insipidus in somebody, and then you're getting urine osmolalities and things like that too.
And again, diabetes insipidus simply means low ADH. It doesn't tell you why low ADH.
Right.
So you're
kind of like, too much.
Great, I still piss in the bed.
Right.
And feeling an albatross of shame.
Exactly.
Can someone help me with why?
Exactly. Yeah. So there are a couple of different ways to prosecute that step 6. And for somebody who's maybe urinating 10 times a day or 10, 12 times a day, something like that, certainly not 20 times a day, we start with Desmopressin. It's a synthetic form of antidiuretic hormone. And we use it 0.2 milligrams. We use that every other night for 10 days or 5 doses over 10 days. It's usually fairly well tolerated. A few people will get headaches and a couple people have had like intensification reactions, but for the most part, it's pretty well tolerated. And what that often will do is it'll cut the frequency of urination about in half. So if you were going, 12 times a day, maybe now you're going 6, 7, 8 times a day. And the really beautiful thing about it is it's a durable solution. It's not, you did it for 10 days, you took 5 whole doses, and yet the decreased urination continues after the therapy, which is really great. Which makes me think that somehow or another you're just retuning the system or recalibrating.
When you first taught that, it was a reset, and then I even watched you taper it once to try and just say nothing to see here, kind of reset.
Right.
Yeah.
The people that are urinating a lot more frequently, 18 times a day, 20, 24 times a day, getting up multiple times at night to go to the bathroom, I don't even try the 10-day because it usually doesn't work. You don't get any benefit from it. What I do find, though, is we have a second way of using desmopressin, and that is, again, to use the 0.2 milligrams. And instead of doing it every other day at bedtime, you do it twice a day for 30 days. And so you're actually increasing the dose by a factor of 4 because you're using a double dose. Well, where you were doing it once in 48 hours, now you're doing it 4 times in 48 hours. And what I usually see is if you're going 20, 24 times a day, you'll drop it to 16. Mm-hmm. Right? And then I have a choice. I can do it again, or I can go to the next shoemaker step and come back to it, which some people prefer that because they still feel like they're making progress. We've reduced the frequency with which they urinate. Maybe we've even completely gotten rid of the nighttime urination. So that's not an excuse to not sleep or to not be rested in the morning. But it's not fixed.
And that's a psychological burden when people have the 3-4 nocturia, 3-4 times a night they're peeing. Because they torture themselves with, I'm not allowed to drink an extra ounce of water consciously and subconsciously.
Right.
And
or drink after 7 p.m.
Or drink up to, and they're starving. Their cells are beyond dehydrated.
Yeah. And that's a real problem because some people do exactly that. They fluid restrict but your body is screaming for more.
Yep.
For more.
Yeah, I tell people again,
fluids.
I get it if you have some kind of taper toward as you get closer to bedtime. But until you get CIRS and ADH corrected, you don't want to hold back on water.
Right.
You would rather top off the tank. I always say you have a Ferrari with holes punched in the gas tank, right? You want to fill it up dry, but keep filling it up rather than just,
Well, and that's a clinical pearl. If you're evaluating a patient and they said they only urinate 3-4 times a day, and you see that their antidiuretic hormone is way low and their osmolality is way high, the next question is, are you fluid restricting? Because that's not a good thing. That leads to headaches and like you were describing earlier. And
I mean, even disorientation, right?
And disorientation,
you could be puttering around in the intersection in a bathrobe and slippers
or an Uber driver.
Yeah. So on that, with the can you speak a little bit, because Genevieve does a lot of the Desmo in our clinic, and we've done very well, and part of that is with your mentorship, but when she's more nervous about it, she's running a complete metabolic panel to keep an eye on that sodium as well. Can you talk about when Desmo could go wrong?
Right.
And this is something because I know this is a podcast, something you absolutely are doing with medical supervision.
Yeah. This is not medical advice.
That's right. Okay? Yeah. But this is, don't get, black market Desmo and start popping it.
There's a couple ways that you can go wrong with desmopressin. One is with kids and also with people that are super sensitive. I don't necessarily start with people that are sensitive, the 0.2 milligram. Sometimes I start with the 0.1 milligram. Sometimes I use the DDAVP, which is a nasal version that's used in children. And it's a much smaller dose. It's given intranasal.
It's like microdosing.
It's microdosing.
Yep.
And so you can start with very low and work your way up as you need to. So that's one way you can get in trouble. The other way you can get in trouble is a lot worse. And that is if you're giving too much desmopressin, and how would you know that? the people will go from having a low level of antidiuretic hormone and a high level of osmolality, and they'll start having a high level of antidiuretic hormone, and their osmolality will drop and their sodium will drop. And when their sodium drops, normal is 135 to 145. I've seen it drop in these patients as low as 125 when I pulled the plug. But I've seen other people under other conditions drop into 100 teens or even the 100 aughts, and then they start seizing.
Yep.
And I don't want to cause anybody to have seizures. So Dr. Shoemaker always recommended that particularly if you're doing the twice a day for 30 days, that you should do sodium, potassium. I add ADH and osmolality. He would say at least once a week.
Yep.
I would say no less often than every 2 weeks, that you're checking that sodium, potassium, and making sure the sodium is not dropping out.
We are 100% congruent on that. And I would say on the front end, it's more important, right? Mm-hmm. Once you and the patient kind of get used to it, maybe you're doing it once a week, but then you go to every other 2 weeks if things are really smooth.
Right.
We have, when I'm teaching docs the Shoemaker protocol, on the correct ADH, you say, hey, we had this couple, they were lovely. They had a good love life and they loved Colorado outdoors. That was their life together, right? It was a nice romance, and then they didn't have kids, and they just hike. Then she gets CIRS. No nature time, no hikies, and let's just watch Netflix again. The biggest thing for her was Desmo. And she felt fantastic. And we told her, once you start feeling better, you slow ramp back into exercise. Don't say, Desmo cured me, and then sign up for an Iron Woman or an Ironman, right? So they went up to Vail. They went from 5,280 to 8,300 feet.
Oh, interesting.
And they were supposed to go for a 45-minute little hike, like just a real green level mild hike. They got lost. They only had a liter of water with them. 6 hours later, they get back to the car, and she's not seizing, but she's disorienting.
I bet.
And they had to go to the Vail ER.
Yeah.
Right. So you don't need to be scared of working on step 6 with a qualified Shoemaker certified doctor, but we are both saying, hey, make sure you know what you're doing with water. Sometimes we'll add LMNT packets or red light or any of those packets and make sure you're keeping an eye on that sodium, potassium. Right. So why are we talking about step 6 so much for a podcast on POTS? Because when you get that perfect symphony of aldosterone, your blood pressure hormone, which is 0 to 30 on LabCorp, and you're going to see the POTS people are 4s and 6s. I had one the other day that was undetectable. Less than 1.0. I hadn't seen that yet. People who are hypertensive, you're going to see are in the 22s, the 28s, the 32s, and they're holding on to too much sodium, which is holding on to too much water, which is increasing blood volume, which is increasing blood pressure. But when you get that symphony of aldosterone, and we do use some adaptogenic herbs to help out a little bit there, you can use Fludricort with your provider with Desmo, or just sometimes the first 3 steps of the Shoemaker protocol: clean building, cholestyramine well call, eradicate Marcons, and sometimes that hypothalamus pituitary and the ADH just resets.
Right.
And you don't even need to get to Desmo. And that's why the protocol is drawn as a pyramid, because sometimes you do the first 2-3 steps and 70 to 100% of your symptoms eradicate. Right.
And I don't put people on Fludricort, but I have seen some of my patients have been put on fludrocortisone either by a nephrologist or a urologist or their PCP. And for some of them, it didn't seem like it was necessary, but for others, it really stabilized them so that they could get through the pyramid, and then maybe they didn't need it anymore after that. And another dosing dilemma that you had talked about earlier, you'd mentioned, was the people that need to stay on antidiuretic hormone or on desmopressin. I had a couple of patients who did that, and that always made me nervous. I mean, they both lived like 200 miles away, so I'm not seeing them that often. They're not getting their follow-up labs that often. Made me really uncomfortable. And then one of them ended up in the emergency room one time because they kept taking their medicine and they weren't peeing.
Yep.
And that is something that I always tell people. If you're going to take your desmopressin, make sure you've peed at least once before you take your next dose. Because if you haven't, you're getting waterlogged.
Do you think that's someone who's taking the medicine and not hydrating enough as well?
Could be, yeah. Particularly if you're fluid restricting.
Yeah.
So I just said, you know what, I don't want to manage your long-term desmopressin. You need to get your local doctor to do that because I can't see you often enough. I can't check your blood pressure. You know, you're not being compliant, and I don't want to, physician do no harm. I don't want you to have seizures because I'm prescribing you this medicine.
Unfortunately, I think 99% of the harm that's happening out there is POTS patients aren't getting screened for CIRS.
Absolutely.
Right? And for our listeners who don't know what CIRS is, again, it's chronic inflammatory response syndrome. You can take a vision test called the visual contrast sensitivity on survivingmold.com. We don't get kickbacks for recommending that. And if you fail and you say yes to 8 out of 13 groups on a clustered symptoms questionnaire, that's 37 symptoms arranged into 13 groups, there is a 98.85% sensitivity. If you pass the VCS like I did during my entire experience with CIRS before I recovered, there's a 95% sensitivity just with the failed clustered symptoms. So there's a 1 in 20 chance you're not CIRS. If you have POTS, every single POTS patient I've ever seen and you have ever seen has the underlying cause of CIRS. Get yourself to a certified shoemaker doctor who is not cutting corners, not urinating, not using urinary mycotoxins and nonsense. Get the proper screening, the proper confirmatory labs, and get going on that shoemaker protocol.
I concur.
And pee.
All that you can pee.
Thanks, brother.
Get an edge on life.